Well, today wouldn't be what it is today without the fabulous Dr. Pehlivan. I was very fortunate to attend the conference in Texas last year, and it was the first time that I really saw the amount of knowledge and depth there really is going on into this syndrome. After coming back from Texas, I emailed Dr. Pehlivan and asked, was there any chance at all he could send a presentation or some words that I could show people here today? He did a lot better than that, and he said, no, I'll come in person. And thanks to him, he is here, and we really, really do appreciate it. On the back of all his hard work, he has organised all the speakers and doctors and physicians that are here today and also presenting for us today. And he's also agreed to become our medical advisor for Mecp2 Duplication UK, so it's just amazing, thank you. As well as that... As well as that, we are also really, really honoured and pleased to have Ionis Pharmaceuticals with us today. We have Mandy Yarborough and Christine Cokery with us. Christine will be speaking to us later on this morning. And amongst us here today, we have a number of researchers and doctors, both from the UK and internationally. And we will be hearing from Dr. Santosh later on this morning. And this afternoon, the presentations are all remote from the doctors over in Baylor College of Medicine, Texas Children's Hospital. They are on webcam, so they can see us and we can ask questions. There is one doctor there that, unfortunately, is so popular, they've become double booked, so they have recorded it. But we'll take questions from email later on if anyone has any. As well as that, we're also honoured to have our counterpart in charities here today. We have representation from Cure MDS, we have representation from the German, the Austrian, French and Spanish charities, and we're really pleased to have you all here today. Thank you. But today wouldn't be today if it wasn't for the Mecp2 children and adults here amongst us and at home. And to make it a family day, we have some entertainment for the children as much as we have so much information for ourselves. So before lunch today, we have a very popular music therapist coming in, Cindy Jo, who's going to do a music therapy workshop with the children. Please do whatever you feel most comfortable. Leave the children in their chairs, get them on the mats, let them move around. Cindy Jo is amazing with the children, so do whatever suits you. And that applies for all of the day. Please be comfortable. We also have with us after lunch a theatre production company that specialises in children with special needs who are going to come in and give us a production. From 11 o'clock, we will have Toby Eyegaze in the room behind us. If you're not familiar, it's an amazing piece of software, eyewear software, and they can use it with their hands, that my son uses an awful lot, and it's amazing. Joe has been to many family days with us, and he is brilliant for showing you demonstrations, questions, so please do go and see Joe if you want to. On top of that, just wanted to say that the toilet, so anyone, well, you will need the toilet, is out the door here and just up the ramp. There is obviously family changing up there. The disabled toilet is more of a baby change, but I don't know if you've seen when you came in this morning, there is a mobile changing care suite right outside the doors here called Revolution, and they have a toilet in there for disabled children, and they also have a full-size care suite, so please help yourself. There's a gentleman in there who is going to use the ramp for you to help you, but obviously once in the care suite there's hoists, etc. You help yourselves. We do have 2 portable hoists in the room here today to help any children with any needs getting in and out of chairs or off the floor. Please do let us know if you need any help. That just brings me on to Mecp2 Duplication UK, just so you know who we are if you need any help at all today. We're a charity run by 8 volunteers. We're all immediate family, mainly parents of children with the condition. We have, over there, we have Rona, our chair. If you put your hand up, Rona. We have Rachel, a secretary. We have Gosha, our treasurer. And then we have Becky, Sharon, Mark, and myself. Is that it? Oh, and sorry, Asha, sorry. You know, I knew I wouldn't get 8. I do everything else, but forget one of them. Sorry. So that's us. We're here. Please don't hesitate if we can do anything at all to help you today. And the only last thing I want to say, and hopefully this won't happen, but in the case of a fire, there's no fire drills expected here today. And in case of hearing the alarm, we have to act as if it is the real thing. As you can see from the well-signposted green lights, there are a fire exit over here and over there, behind us here, and there is one. I can't see it because of the lights, but there is one in the far corner there. I do know that the one over here and the one over there is step-free access. So it's best to go that way if we can. We will obviously all help each other out. And the assembly point is a very, very tall light post in the car park over there. And once we get out there, heaven forbid it happens, we then become under the control of the fire wardens of the hotel. Right, just wish you all a really lovely day. If you need anything, please don't hesitate to ask, and I'll hand you over to Dr. Pehlivan. Thank you.
Thank you so much, Helen, for introducing. So, do we have a pointer to present? Where is it? Oh, thank you. And first of all, thanks for the invitation. As you know, Mecp2 Duplication is my almost entire life, except my private life. And we are making truly progress. And you're going to hear from Kristin today that we are getting very close to trial. I know you have been working, waiting for this for a long time. And this all happened because of you, okay? Mecp2 duplication is an extremely rare condition, okay? It's not like even compared to Rett syndrome, it is 10% of the Rett. It's 1 in 150,000 individuals roughly. So it's extremely rare, but the participation on family sides makes the difference. That's why we are getting very close to treatment, hopefully, for this condition. So I'll talk about the genetic studies because, genetics was playing a role in Mecp2 duplication syndrome that I'll explain, and we'll go from there. So first of all, Mecp2 duplication syndrome is a genetic diagnosis. What does that mean? There is a region on the chromosome that I'll show you. The duplication of that region, that means there is an extra copy of that region causes the disease, okay? It's a genetic diagnosis. What does that mean? You can't look at a child and say, oh, this child has Mecp2 duplication syndrome. Even the best dysmorphologist, Dr. Van Ash, is here today. So you can diagnose clinically a child with Mecp2 duplication syndrome. You have to have a genetic test for that. And there are 2 X chromosomes on girls and 1 X chromosome on boys. That's why the girls mostly doesn't show the phenotype. In rare condition, there's a milder form of Mecp2 duplication syndrome. So this is a real chromosome structure, and X chromosome is this one. And as you can see, this is a male individual's chromosomes. There's 1 Y chromosome, there's an X and Y. And Mecp2 is all the way here towards the end of the towards the end of the X chromosome. This is important that I'll explain you why, okay? Because being towards the end of the chromosome. There are some large cohort studies. Peter's done it from US Natural History Study. That's a different natural history study than what we are doing in US now. Lim et al. Did it from Australia, and the Miguet did their French cohort. And they all showed that there is a clinical variability. By the way, can you hear me? My voice okay? Okay, perfect. And so what we thought, we were working on the Mecp2 duplication genetics since 2008 or so, after the, like few years after the discovery of the Mecp2 duplication syndrome. We asked whether the genetic studies plays a role in this clinical variability, okay? So the above, this is an array CGH. That is how you mostly detect Mecp2 duplication syndrome, okay? This is the Mecp2 gene, and these black or the red dots are probes that shows whether there is a deletion or duplication. Duplications are mostly red, and the normal copies are black. Here, few scattered dots are not important. You need to have consistent red to say there's a duplication there. This is a commercial array. That means a diagnostic lab array CGH targeting to detect Mecp2 duplication. And below is our high-resolution array. We specifically designed an array to cover the region. That's 11 times higher resolution than the commercial array. And you can see how nicely it can detect the duplication. So when we did this Mecp2 duplication study on our initial cohort, we found different structures. I'll tell you what those are. This is formerly simple duplication. Several of you may have heard it from me, simple duplication. Now we call it tandem duplication. It's because more medically more or scientifically more accurate naming, because there is only one duplication event, and Mecp2 is here within that red zone. This is terminal duplication. That means, as you remember, the Mecp2 is towards the end of the chromosome, and this duplication reaches all the way towards the end of the chromosome, and Mecp2 is again in the duplicated area. Here is the Mecp2 region, and this duplication reaches all the way end of the chromosome. And here's a triplication. It's hard to see, but this is again in the duplicated region, but there is an area, blue bar here, and you can see the separation here. Sorry about that. Look, this is normal, come a little bit increase here, and there is more increase here. That's called triplication. Duplication, triplication, duplication event. That's, if it includes Mecp2, we call it Mecp2 triplication. But there are several triplications in the region, but not including Mecp2. They are counting as normal Mecp2 duplication still. And here's another duplication, normal duplication event. Mecp2 is in one of the duplicated area. Okay, and here's a translocation. I am not sure if you have seen, you may see it in your diagnostic genetic test. There's a duplication, but also there's a deletion of another chromosome, here chromosome Y, and that is when it happens in genetics, a deletion in one region, a duplication in the other region, that's mostly a translocation. So this is a translocation case. Back in 2009, we published the initial cohort of 30 patients. As you can see, the genes are on the top, and these horizontal red bars are Mecp2 duplication, okay? And you see how many genes are involved in this region. So what is it important? Every child has a different size of duplication, okay? They all have different gene content and gene structures. But the overlapping genes are Mecp2 and IRAK1. If you horizontal dashed line, you see these only two genes are Mecp2 and IRAK1 genes. So these are the only duplicated. As you can see, there are some triplication including Mecp2, or there are some triplications not including Mecp2. Okay, so this is from 30 subjects. We found that there is about 25% of the Mecp2 duplications have complex duplication. One important thing I wanted to highlight here, this is human, right? When you do mouse, they always have same duplication. That's why when you do clinical trial on mouse, you see much more robust differences. That's one of the reasons you don't see the same results on human, because the mouse has same genetic structure, same background. That's why it's easy to study, and you may find the different results when you do the trial on the human subjects. So the big messages are Mecp2 and IRAK1 are the only duplicated genes, and the structure is very different in each individual, and it sometimes has triplication or complex duplications in the region. So based on that, I kept talking to you. It was simple duplication, a complex duplication, and a triplication including Mecp2. But the complex duplication was including a bunch of different structures. That was including duplication, normal duplication, duplication, triplication, duplication, not including the Mecp2. Translocation, terminal duplication, there's a bunch of other much rarer complexities as well. This was back in 2009. I started Texas Children's Red Center in 2017, started collecting samples again. Several of the patients here provided samples back in 2009, 10, 11. I see them here. So now we have 137 individuals. Thank you so much for all. You try to participate from Europe as well. And most of them are from US, as you can imagine. Majority of them are evaluated at Texas Children's Hospital. That means I personally evaluated them. And we did, several of them were published previously, as I said. And I developed a clinical evaluation form that we applied to everyone, so that we will have a more structured like clinical evaluation form. We used that, and we measured the developmental quotients. It's the kind of IQ of the development that measures where you are at with the development. At that time, 2009-10, we were only doing array CGH. Now we expanded to different genetic technologies. These are new: long-read whole genome sequencing, short-read whole genome sequencing, or optical mapping. These were not present back in old days, and these are very cutting-edge genomic technologies. Okay, so now we increased it to 137. What we found, not 25% of the duplications are complex. Actually, it's more than 50% are complex duplication, 49 to 51%, okay? And the terminal and the others are triplication, duplication, dup normal dup. This triplication is not Mecp2 triplication. It includes both non-Mecp2 triplication and Mecp2 triplication. And terminal duplication makes a big cohort, but it includes the translocation group as well, because all translocation groups have also terminal duplication. So I had shown some of these slides in our last year's conference. These are new updates because we are about to finalize the paper, and these are the clinical information from that. I won't go all of them, but I wanted to show some highlights. From tandem duplication all the way to triplication, okay, the severity overall increases. I'll tell you some. For example, in the tandem duplication group, there is a normal birth weight is a good thing, right? You have a normal birth weight. But as you go from 92% to triplication is 40%. It gradually worsened, okay? And the p-value means there's statistical, scientifically, there's a statistical difference. All these are statistically different. Normal birth weight, postnatal complications. When child was born, they went home or they stayed in the hospital. Again, from 36% to 100% in the triplication group, it worsened gradually, okay? Same for congenital hypotonia. The hypotonia, low birth tone, like loose baby, it again worsened from 0 to like 50% to 100%. Epilepsy. Epilepsy is the major hit in this condition, okay? Epilepsy did not differ between groups, okay? But it's 59%, 40, 50, 45, whatever. It doesn't vary. And when you look at the large cohort studies, they don't show any difference about epilepsy. However, age of epilepsy onset varies between groups. In the tandem duplication group, the simple duplication, age of onset for epilepsy is close to 9 years. Okay, 9 years, 10 years, there is a variation from individual to individual. Whereas, and this is like 8, 9 years, this is about like 7, 8 years. And when you go to triplication or the translocation group, it's around 4 years, okay? From 9 years to 4 years. As you know, epilepsy in these children are mostly refractory, okay? From these 137 patients, I think there's only 1 or 2 who does not have drug-resistant seizures. Different than Rett syndrome, other disorders. In Rett syndrome, only 1/3 are drug-resistant, but in Mecp2 duplication, it's almost universal. Almost all children with Mecp2 duplication will develop seizures. We know it. But the age of onset of that epilepsy hits and becomes refractory depends on the genomic structure. Okay, same for microcephaly. In the tandem, microcephaly means small head, right? You call it microcephaly, I guess, in UK. So 3%, only 3% has microcephaly in the tandem simple duplication group. It's 8%, 55%, 76%. Triplication is 2 out of 3. Don't forget that we have Mecp2 triplication only 5 subjects, and we don't have information on all of them. So that causes a big variation, but still, this is the much sicker patient group, Mecp2 triplication. Same for G-tube feeding. They all have problems with chewing, swallowing, constipation, but the requirement of tube feeding, 35% to 100%. Okay, they all need tube feeding from this order. Same for CACUT means genitourinary abnormalities. It's still high, but the severity worsens. They have more urinary or genital problems in the triplication and translocation group. These are other features from our structured clinical table. There is sometimes partial trend, okay? For example, there's 47%, 40%, 37%, but 80%, 60%. So it's gradually increases. And there's still a bit ups and downs between groups. But overall, there's a partial trend, or if there is no statistical difference, they are highly common. Pneumonia is very common. Recurrent upper respiratory infections are common. Constipation is very common. Reflux is very common between all groups, 80%, 90%, 75%. All these features, high pain tolerance, teeth grinding, whatever you call, they are mostly common between groups. That's why you don't see a statistical difference, okay? As a neurogeneticist and doing a lot of genotype-phenotype comparison, phenotype means clinical feature, genotype is genetic structure. This is a very robust genotype-phenotype comparison, very solid. I talked to you about developmental quotients. What does that mean? Developmental quotients means, or developmental skill means, when a child develops certain features. Will they walk, or will they, like when they start walking, if they walk? Or will they start eating by mouth using their hands? Or will they say any words? All these features, okay, if you see from tandem duplication to triplication, these two groups are very similar in general, but there's a trend down. The developmental skills worsens between groups. Again, same for highest achieved. For example, a tandem duplication child achieves around 15 months of level skills of a child, mostly. But triplication gains about 3-4 months of level skill. Okay, again, worsens between groups. This was gross motor, that means your strength, body, and your legs. Fine motor is for hand skills, like whatever you can achieve. Still, you see same trend. It worsens gradually. There is still ups and downs, but still there is a trend between groups. Survival. These kids live shorter than Rett syndrome. Okay, Rett syndrome was more known, right? But we have several kids in their 50s, 60s that we follow at Texas Children's Hospital Rett Center. Mecp2 duplication, survival is much shorter. Still, we have like 55 years old, I think, from Italy. Everyone knows, I guess, him. So tandem duplication is this. They live the longest, okay? But triplication is here. They live much shorter. And this is the terminal translocation group. They come second. They live second shortest. And the other complex lives longer, closer to the tandem or simple duplication group. Survival significantly varies between groups based on the genetic structure, okay? But based on that new information, we have now over 130 samples. Now tandem simple duplication is separate, triplication is still separate. They're two different, but the complex duplication is divided. The translocation and terminal duplication are much more severe than the other complex. And this complex duplication is more close to tandem duplication when you look at it. So why this is important? This is Mecp2 gene function level, okay? You have about a buffer range, a little bit ups and downs, but if you have going down on the Mecp2 level below, it causes Rett syndrome. Too much will cause Mecp2 duplication syndrome. It's very fine tuning, okay? So if you're within buffer range of, let's say, probably around 80% to 120, 30% of Mecp2, you're normal acting. Over 130, 140%, you have Mecp2 duplication. Or below is below 80%, 85% is causing Rett syndrome. Severity worsens, of course, when you go up or when you go down here. So when you have ASO or any other genetic therapy trial, because these are targeting the root problem, right? The problem is too much Mecp2. If you wanted to target, let's say you have a Mecp2 level of here, okay? If you target insufficient, you are going to still stay within MD Mecp2 duplication phenotype. You have to have a perfect, this middle row, going from whatever percent to normal level, then you will probably have a Mecp2 phenotype recovery, okay, MDS recovery. And if you do too much, you are going to convert to Rett syndrome. Same on the other side, if you treat Rett syndrome too much, you are going to call Mecp2 duplication. Insufficient, you are going to still stay within the blue zone, Rett syndrome. You have to go to ideal dose, okay? So that is what we are dealing for when we are trying to launch the clinical trial. So the summary of Mecp2 duplication, our studies is, this high resolution and the cutting-edge genomic technologies shows that there's a complexity, and it's too much. Half of them are complex. And these different types of genetic complexities has role in the clinical severity, okay? And for now, the severity is from tandem or simple duplication. They are very similar to complex, these two, but they are better than terminal duplication and translocation. These are relatively similar, and the triplication is the most severe. So we are still working on trying to show this. We have the DNA genomic duplication, and we have clinical phenotype. In between, there is the protein and RNA, which are another studies. We are working on it, but it's difficult to show it because Mecp2 binds to DNA. That's why you don't measure it very easily. Huda Zogby is working on it, okay? That is, she's working on this gene for 30 years. And this is the best lab who can assay them, who can test the experiments, but still working on it. It's not easy to show. And as I said, based on the level of the genomic structures, maybe you will need 4 times or 3 times or just 2 times those of ASO or whatever the treatment will be, okay? So that's why this genomic structures plays a big role. So I wanted to say that, I mentioned this, the protein or the RNA studies. We are still recruiting for genetic studies. I mean, we are going to publish these results hopefully in the next few months, okay? We are going to submit it. But still, we are collecting and we are still doing research to understand these different complexities, if some of them plays big role or not, and whether it plays a role in more tuning of the medication or other genes in the region contributes. There are several genes cause neurodevelopmental disorders, and we are not accurately measuring them. We are doing a lot of genetic studies. That's why you should participate in genetic studies as much as you can. So ideally, we are getting samples. We are from all around the world, but it's challenging to send samples from here, Europe to US. I brought some kids, so kids who were not enrolled in the genetic studies. During the therapy session today, I'll stay at the corner, draw blood if you're interested in, okay? So with that, I wanted to thank, of course, Huda Zogby, my mentor, and without her support, we wouldn't be here talking about when the trial will start. And the Texas Children's Rett Centers, you're going to hear from these clinicians. We are a large center, and we have these clinicians are very expert on Mecp2 duplication. So if you have clinical questions, any symptom problems, you can mention them, you can ask them. My mentor, Jim Lopsky, who started the genetic studies, former mentor, now separated from Lopsky lab. Claudia is running the genomic studies in Seattle, PNRI. And these research studies were supported by IRSF, which is RSO, Rett Syndrome Organization, Cure MDS, and I have NIH funding and Doris Duke funding. With that, thank you so much, and happy to take any questions you have. And I don't know if you know Dr. Van Esch, who introduced or who discovered the Mecp2 duplication syndrome first in human, okay? So she's gonna run the first morning session, okay?
So we don't take questions now? Are there any urgent questions for Dr.?
Yeah, because we are behind,
yeah. One quick question.
Miss Sarah, yeah. You can speak loud. We'll repeat. Yeah.
Hello?
Yeah.
Just very quickly, and I'm just wondering if this has changed. With the ASO treatment then, will the dosing of the treatment be bespoke for each child depending on their duplication, or is that part of the study as well to, oh, I'm asking the wrong person.
She's yeah. We are going to answer.
Yeah, so we can start that discussion now, but I think we'll probably save it for my discussion. But that's what the clinical trial will demonstrate, whether or not it will be a personalized medicine approach. So we will be evaluating multiple doses and then looking at it from the standpoint of the variant structure. And that will help us understand if, from a commercial standpoint, if Ion 440 is demonstrated to be safe and efficacious, whether different children will need different amounts of therapy. What we do see with one of our approved products, which is Spinraza, is that these children that started treatment at 6 months of age, 2 years of age, eventually become adults. And so we do need to think about how do we scale up when our children are now doing much better and they reach adulthood and they're going into adulthood. So important considerations for the clinical trial and then in the future. Great question.